Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Bristol Myers Squibb.
Well, welcome, Alex, to the podcast. Thank you so much for joining us so that we can have a bit of a conversation today and learn a little bit more about refractory symptoms and hypertrophic cardiomyopathy and how we approach that and manage that for patients. My name is Maddie Smoot. I'm one of the UVA General Cardiology Fellows and interested in inherited cardiomyopathies. So thank you for letting me pepper you with some questions today.
Yeah, happy to be here. Thank you for having me.
Yeah, we can jump in. I think one of the things that's very helpful for people is starting with the definition of what refractory symptoms would be for a patient with hypertrophic cardiomyopathy. A patient who might already be what we would call optimally treated with current standards of care and how we would approach that.
Yeah, so I think you can think about it a couple ways. I think refractory symptoms in someone that has obstructive hypertrophic cardiomyopathy, where they have obstruction of blood flow, versus someone that's non-obstructive can be a little bit different. When I have someone that I know has a history of obstructive HCM, and I think I've got them on all good meds, and their resting echo doesn't show any obstruction, but they're still giving me, Alex, I still get short of breath with inclines. Sometimes after eating a really heavy meal, I'll feel a lot of palpitations and shortness of breath just like I used to all the time. And maybe it's not as severe, but I still feel that. If they tell me things like that sound like purely obstructive symptoms, then I want to make sure that the refractory symptoms are really refractory to being non-obstructive versus am I missing the obstruction? And so if you look at folks with HCM, 2/3 of them will have obstruction across the board, and 1/3 of those are purely with provoked maneuvers. And that could either be with a really good Valsalva on a resting echo, or with goal-directed Valsalvas, which is something we do now at Penn, and Matt Martinez and Dermot Phelan and a couple of others champion that, where you have the patients blow down on a flexible tubing into a sphygmomanometer and try and make them generate a certain amount of pressure just to make sure they do a really good Valsalva. But what I will say is that sometimes we miss obstruction even with that. And so I try and exercise a lot of my patients. And I've had many patients where you don't see anything on a resting echo, nothing with Valsalva, and then you put them on a treadmill. And even if they've been on a myosin inhibitor and they've had no obstruction, I put them on a treadmill and I find obstruction on the treadmill when their heart rate's above 110.
I see.
And so with my obstructive patients, I really try and tease out to make sure I've gotten all of the obstruction, because I will say most obstructive patients will feel really good if you've gotten rid of all of the obstruction. Non-obstructive can be harder because non-obstructive patients, there is no gradient to target. They have a lot of the same physiologic issues apart from obstruction that obstructive HCM patients have. They have thick hearts, small cavities. A lot of them can have fibrosis and diastolic dysfunction and arrhythmias. And so diastolic patients with refractory symptoms, I will also at some point confirm that they cannot obstruct. And sometimes you'll look at their echo and you look at the way their mitral valves are shaped, and you're like, there's no way this patient's ever going to have obstruction. And so you can feel confident about that. But every once in a while you're fooled, and someone that's been labeled as non-obstructive has the capacity of being obstructive, so falls into that labile obstructive population. But, with those patients, I will, make sure they're on all the meds. And there's varieties in practice of what we put patients with non-obstructive HCM on. What I would say is, unfortunately, we haven't gotten to the point where we have targeted disease-specific treatments for non-obstructive HCM like we do with the myosin inhibitors and obstructive HCM, but that's changing. There's a lot of trials going on now. So in a lot of my patients that are already on a pretty good heart failure with preserved ejection fraction med regimen, so you've got them on a beta blocker, you've got them on an ARB or Entresto, you've got them on spironolactone, you've tried a SGLT2 inhibitor. A lot of those patients I will consider clinical trials. And so there's ongoing clinical trials in combined SGLT2, SGLT1 inhibitors. There's a clinical trial for a lusitrope for a company called Edgewise that is enrolling non-obstructive patients. And then there's up-and-coming trials for different disease mechanisms, looking at, targeting fibrosis and these thick, stiff hearts, looking at targeting energetics and shifting the way that the mitochondria, produce energy. So there's trials for non-obstructive that are coming too. And so in my mind, if I've got my patient on all these meds and they're truly non-obstructive and they still feel terrible, then I offer them trials at our center.
Okay. Is there any work in the GLP-1 space for patients with refractory symptoms and non-obstructive HCM specifically?
Love that question. When I was in your shoes as a fellow, I suggested that and was told the SGLT2s were the thing and blah, blah, blah. So I clinically have been putting many of my patients on GLP-1s because there's good data that's been published by large groups, smaller groups. When I was a medical student, we published on this, that obesity worsens outcomes in HCM. And, I tell my patients, you already have symptoms at baseline. Imagine carrying a 50-pound book bag every day. And that's what this is right now for you.
Yeah.
And so we've looked at it some in GLP-1s, especially GLP-1 concomitant use with mavacamten, but also there are supposedly trials upcoming of GLP-1s in this space. I personally think that you probably will see significant improvement in symptoms in both obstructive and non-obstructive. And I wouldn't be surprised if you saw improvement in symptoms in obstructive patients that are still obstructed. Because I think that there is a mechanism behind obesity and HCM that extends beyond obstruction. And I've anecdotally seen many patients go from like a class 2 to a class 1 just with weight loss, and they were not obstructed to begin with. And so there's definitely an interplay there that I think needs to be further studied. Probably next year or two, we will see a trial.
Yeah, well, that would be great. I know that, that arena is expanding in multiple cardiovascular spaces. Thank you for commenting on that. I think another thing is, and we've touched a little bit on that, is when you start thinking beyond obstruction as a primary driver of our patient's symptoms. And, is there a red flag or a marker that you're looking for as someone who's attuned to these patients and is an expert in their care, that you're seeing in clinic and saying, okay, this is pointing me in the direction that I need to be thinking about this?
Yeah. I'm a big fan of cardiopulmonary exercise testing with imaging. So I've had a couple patients that have been sent to me. It's like, oh, this patient's on mavacamten, and we've gotten rid of the obstruction. There's no outflow tract obstruction, but they're still symptomatic, especially with exertion. And I've now had 3 patients that when we exercised them, we discovered that there was worsening of primary mitral valve disease. And one patient, like, just flat out, we got rid of their obstruction and their mitral valve was just destroyed. So what we thought was SAM-mediated mitral regurgitation that was going to get better with relief of outflow tract obstruction, they still had severe mitral disease. And so I think thinking beyond the obstruction, making sure that like primary mitral valve disease is not the issue, because in those patients, I actually had to wash out their mavacamten and send them to the OR and have their mitral valves replaced. So I've noticed that. You also want to make sure you don't have someone that's transitioning from a hyperdynamic typical HCM phenotype into the early stages of a restrictive or burnt out end stage HCM. I think in the community, patients sometimes will be overlooked with an EF of 50 to 55 because that's low normal, when these folks are used to living at 75. And so the net drop there is significant. And so in those patients, if I start to see that and I get a CPET and I see their VO2s are coming down, I start quickly shifting my medical management away from like, Definitely stop the calcium channel blockers, start shifting more towards beta blockers, goal-directed medical therapies, talking about ICDs if they don't already have one, because those are the ones that I think can slide past us. And
Mm.
also post-septal reduction therapy. Like there's a subset of patients, and there was a small signal for this in the SHARE registries, that there might be an increased risk after septal reduction therapies, especially like myectomy, that you take a big whack out of the septum, they now have a left bundle branch block, there's some dysynchrony there, that sometimes those patients will live with a low normal EF and could eventually progress. And I think it's hard to say if that is due to procedure, or are you kind of narrowing for a population of people that was sick enough in the first place to need an intervention, and they may have progressed regardless of the intervention over time. That's a small subset, and depending on where you read, up to 5 to 10% of HCM patients will transition from a hyperdynamic LV to like a mildly decreased restricted phenotype. But it's an important one because those are the people that if you don't catch them early, you don't do your CPETs frequently, start talking about transplant earlier, those are the ones that you can get in really bad problems with quickly.
Yeah. So what I'm hearing is, we need to be thinking more about maybe considering objective testing and using CPET even earlier when we're meeting these patients and thinking about them as a whole.
Yeah, for sure.
Yeah. And that kind of delves into, one of our next topics, which would be touching on how you can use imaging, whether that be, CPET, repeat echo MRI, those sorts of things to touch on patients' unexplained dyspnea if they are reporting that to you in clinic. Is there a way that you're using that in a standardized fashion to monitor, preemptively, or is that something that you can trigger when they report dyspnea to you?
Yeah, I mean, I think that so MRI we do every 3 to 5 years. That's more to look for a progression of risk factors if they don't already have an ICD. I think that some tests, the exercise testing is probably the most helpful test. Looking at diastology and filling pressures at peak exercise can be helpful, or worsening, like, are you unmasking pulmonary hypertension that wasn't there? I think that nuclear testing, so PET scans, can have a role. I think what they a lot of times show, and Paco Bravo, who's one of our nuclear cardiologists here, did some interesting work on this a while back. You will see evidence of microvascular ischemia on a PET in a lot of HCM patients. You will see transient ischemic dilation, global ischemia on
Mhm.
HCM patients with no coronary disease, with no large vessel disease. And so there's definitely some of that going on, which is probably what's driving, the scar, and what's driving, like in some of our apical HCM patients, is driving the worst, like apical aneurysms and things like that, is from, a heart that's grown so thick that it's outstripped its blood supply. I don't really use nuclear testing though that often for like diagnosing those things, because to me it's kind of implied. But I think exercise testing, and then, if you're not sure, a left heart cath and a right heart cath can be very helpful. Left heart cath to suss out, are you missing obstruction in your, as you brought up earlier, obese patient with HCM that doesn't have great windows, and you're not sure if you're seeing anything there. A very carefully guided hemodynamic study through the LVOT with PVC provocation to look for that inducible obstruction can be super helpful there. And then a right heart cath to look at filling pressures. Pulmonary hypertension is a thing that can happen after chronic left-sided HCM disease. And some of our sickest patients have really bad pulmonary hypertension too. And so every once in a while, I will also lean into a left heart and a right heart cath to help me figure it out.
Okay. Interesting. And then, in this today's day and era of invasive coronary function testing, if you're thinking about microvascular ischemia, playing a role as well, are you doing any invasive coronary function testing as part of your workup to look for things, like you said, beyond epicardial disease?
Yeah, we haven't really done a lot of invasive coronary testing. And I wonder if that is probably more common in some places where you have HCM docs that are also interventionalists, that kind of falls more into their wheelhouse. Here, I specifically would love to see more invasive hemodynamic testing, like and exercise testing, like level 3 CPETs. We don't do it as much at Penn, and I don't know if it's just a cultural thing. I'm not sure if UVA does more of those, but I feel like that would give more data, like to see the dynamic. Because a lot of our patients, you lay them down and you check their filling pressures, and they're fine. But if
Yeah.
you put them on a recumbent bike and you had them increase their heart rates, you would see their filling pressures skyrocket.
Mm-hmm.
And that's probably the answer. But I haven't done that much invasive coronary testing. But it's interesting, like a lot of, and it's probably partially a decrease in demand and that you see this change. But if you look at like patients with both obstructive and non-obstructive HCM, and you put them on a myosin inhibitor, and all the trials, you've seen drops in their troponin levels, and you've seen drops in their NT-proBNP, kind of taking the pressure off the left ventricle. I imagine that's probably improving the supply-demand mismatch and improvement in perfusion to the endocardium when you decrease the contractility. But what it's doing at the coronary level, I'm not sure. Unfortunately, like even with the non-obstructive trial, like Odyssey, which didn't meet its endpoints for improvement in CPET and NYHA, those patients still had significant drops in their biomarkers, like improvement in troponin and NT-proBNP, just from decreasing their contractility, even though there was no obstruction to begin with. So there's definitely blood flow and supply-demand mismatch changes that are happening.
Nice. Okay. Well, I think, we've definitely gone through a few things to think about, especially for folks like myself and others that are not necessarily, HCM experts right off the bat in terms of thinking about patients who might already be classified as well managed and, they're still presenting with bothersome clinical symptoms, things like, thinking about CPET earlier and thinking about HFpEF management and the non-obstructive folks and invasive hemodynamic assessment, those sorts of things. Is there anything else that you want to leave the audience with and, in commentary on, a highlight or a pearl that we've maybe not touched on when it comes to patients with refractory symptoms?
Yeah. I think probably what I've noticed the most is that when I see patients for the first time, they'll tell me, I've never been asked that question. And some of the obstructive symptoms are very unique. Like the postprandial symptoms that patients will tell you, like they'll say, Alex, after Thanksgiving, I always feel awful. Like I had a
Mhm.
big meal, must have been the tryptophan. Like, do you feel bad after any big meal? It's like, yeah, actually I do. I feel more palpitations, more shortness of breath, harder getting up a flight of stairs. Some of the targeted questions get at the symptoms better than, oh, how do you feel? Because most patients have lived with these symptoms for a long time. And so for them, they've worked around the symptoms and they catered their life to live with them, and they think that that's reasonable. But if you really dig down, they're more symptomatic than you realize. And even like scores, and I've argued about this with multiple people, like the KCCQ score, you know, most of our patients don't have lower extremity edema. Most of our patients don't have an issue walking on a flat surface. Most of our patients, push through a lot of this stuff and still feel like they get to do the things they want to do. And so I feel like one spot that we miss is asking the right questions. And then even if you do ask the right questions and you do the diagnostic testing, the initial one, I feel like we're not exercising people enough. We're not doing enough provocative testing. And you'll miss patients that, maybe have mild hypertrophy, but have an abnormally long anterior leaflet and can obstruct at peak exercise. And they never get Valsalva maneuvers at rest because, the walls don't look that thick. So they're not seeing much at rest. So they don't see why would we provoke them. So a lot of those patients, if they sound like they have obstructive symptoms, which is hard because you can overlap that with a lot of other symptoms. But I think that an obstructive test is everyone deserves to get some sort of exercise test, if they're able to do it, to prove that they can't mount that physiology. Because that's what I see the most is patients come and they feel great. They just wanted to make sure they were covering their bases by being seen in the center, or they just came for genetic testing. But then when you really dig down, they don't feel that great, and we're probably missing something.
Well, I really appreciate your time today. Thank you for going through these. I think this is, again, super helpful for those of us that, may not either be at a center of excellence or just are not ourselves, don't wear the primary HCM hat. So thank you so much for taking the time today.
Yeah, my pleasure. You've got a great center there with you, so you got a lot of good people to learn from.
Absolutely.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.